Okay, so I'm going to discuss how you are going to do short cases in pediatrics because uh, I'm doing this on your request actually. This is not a scheduled lecture. So can you all hear me?
Yes, sir.
Yeah. So it's better if you all can speak and clarify your uh, doubts then and there rather than waiting till at the end. Um, so I thought to do this in 2 sessions because it's not easy to do all short cases in one lecture, and also you will also not be able to tolerate this. So, right. So the first thing, so you need to know the spectrum. What are the cases that you are going to get? So CVS will be the highly likely case because it's very easy to find children with murmurs from cardiology clinic, and we might call them and get them to this exam. RS will not be a case for this exam. Can't say no, but it's bit unlikely for you to get respiratory system uh, because of this COVID thing. But having said that, uh, children with chronic lung diseases, sometimes those who had PCR test done and negative, and also children who recovered from dengue hemorrhagic fever with pleural effusions can come in your respiratory system exam. So that is a possibility, but majority of you will at least uh, 2/3 or 4/3 of the batch will get CVS case. Abdomen, definitely you will get abdomen cases. CNS, very common in any exam you will get. But even though I put CNS and under 3 terms like cranial nerves, upper limb and lower limb, sometimes the lower limb examination command may not be CNS relevant as well. Because children with erythema nodosum, children with HSP, children with rickets, so we will ask you to examine lower limb. But it's not a neurological examination, but the general examination and the relevant. So then the developmental assessment, I did not put a case like miscellaneous, but even because sometimes skin rashes we might give, but we are not that keen on giving skin rashes because it's bit spot diagnosis like OSCE based thing. Hardly anything for you to do like examination techniques wise. You don't need to do anything in skin rashes and all, right? So we will be mainly focusing on CVS, abdomen and CNS. Today I'll be discussing on CVS, RS and abdomen. On another day before your exam, I will do because it's a bit difficult to prepare a slide presentation for this kind of a lecture as well. Because everything is uh, based on physical science, how to present and all. I don't know what's the best way of discussing this kind of a thing, but I will try and you can give your comments at the end. So let's start with cardiovascular system examination in children. Please keep this in your mind. Though we say children are not miniature of adults, but older age children, you should examine in a way you examine an older person, right? You can't have shortcuts, and you might forget certain things, and at the end you might say, okay, because of a child, I didn't do this. Those things are not allowed. But if it is a small baby, tiny baby, maybe a child, even a young child who's not that compliant with your examination, sometimes you might have to change the order of examination. But you should never change the order of presentation. You might start with listening of precordium, but you should not start with presenting precordial findings. So it's the presentation is it's almost like an adult. So common pitfalls you will get at the end of examination is, so you can't remember the age of the child before going to present. Then again, it's not that nice. Be conscious. Be conscious at the time of exam. Okay, how old is this child? Well, at the time of presentation, only you are going to, oh, I couldn't ask the age. Right? If you can ask the age and the name, even name also fine. In the abroad, in other centers, they start with selling, I examine this 10-year-old so and so. And you all start with 10-month-year-old. That's also frequently encountered, and it at least 50% of you all will tell the age like that, 10-month-year, right? So be conscious, 10 months old or 10-year-old, that's it. Right? And also don't look at the patient during your presentation. Keep your hands back or wherever, keep in a comfortable, confident position. Don't just lean forward and don't show the examiner that you are incompetent. So your findings may be incorrect, but be confident. So those things will carry marks. Not that we are exactly looking whether you are confident or not, but the way you present. And so presentation skills will get significant amount of marks. So don't say lying comfortably on the bed for all cases. Like in CNS, like this is lower limb examination, this statement is not needed. Like, but it's very important in CVS and RS examination, that kind of a statement to begin with. And also don't say no fellow, no cyanosis both, right? So cyanosis means, so in cardiovascular system examination, if you can say child looks pink and no cyanosis, that's all, right? So because these are opposite things. So I have put all my thoughts in these slides. I have not gone through any textbooks of any McLeod or Hutchison's. I have put all my thoughts in a way I teach you all in a word class. I would have told this kind of things to the last group, but may not for the others. So in cardiovascular system, you can follow all the steps if the child is older. So don't ask me up after which age. I can't tell you, right? Because you will get most of the time, you will get bigger children's cardiovascular system examination, right? So start with auscultation if the child is young and likely to cry. Looking at the child, sometimes you will realize, okay, child is not that compliant with what you are going to do. If child is around less than 1 year, definitely better to start with auscultation of the child before precordium before you are going to mask the physical signs. You can auscultate while on mother's lap. And if child started to cry, if it is a breastfeeding baby, you can ask with the permission of the examiner, so can I ask mom to give a feed? Of course, yes, because that's the most comfortable thing for children. So they will be happy with that, and you can jolly well examine the listen the precordium. Do not auscultate over clothes, because that is something some examiners tend to penalize, but in real practice we might have to do this, but in your exam don't auscultate over clothes. That will be a serious mistake, right? That doesn't mean you have to take the top off, but you can just lift it up, right, based on the age of the child, right? So there are 4 components in the cardiovascular system exam. General exam, this is the way I classify, and I used to learn and I used to teach. I couldn't find these things in a book, but I classify like this: general examination and peripheral. CVS means circulation, right? And then the precordial examination and associated symptoms like systems like lung bases and liver. So very rarely you will be given the command examine the precordial rather than saying examine the cardiovascular system. Very, very rare for you to get that state. And before going to these things, I will tell you the time. We don't count the time for your short cases. Roughly, we believe we are going to do 2 short cases in 20 minutes. So one short case is 10 minutes. Out of that 10, we expect you to turn to the examiner's side at the end of 6 minutes of your examination. But that 6 minutes is not for you to examine only. Examine, take time to examine for about 4 to 5 minutes and have at least 1 minute for you to kind of organize your thoughts. How are you going to present? What is the age of the child? Boy or a girl? So that kind of things, right? So cardiovascular system examination, you will take probably almost around 4-5 minutes. Respiratory examination also like that, but abdominal examination is quick. Usually you will have lots of time left, right? So precordial examination, inspection, palpation, auscultation. In cardiac CVS, we don't expect you all to focus for the, heart, over the heart, we don't expect you, nothing you are going to gain. And systems wise, lung bases and liver. So we look at whether you have touched all these four components, but some of you all might not examine the liver, examine lung bases, so you might forget, right? So keep that in your mind. So what are the things you are going to do in general examination? So general examination has to be relevant to the system. So it is now neurocutaneous manifestations are not there is not an statement you are going to give in cardiovascular system examination. But cyanosis is not something you are going to mention in CNS examination. So likewise, don't try to have a comprehensive list. Don't try to have a comprehensive list. So when we ask you to make some cards and all, you are trying to put all the things under the sun in the general examination to make your card more kind of elaborative. But at the exam, you will forget salient things. So I will put very few things, but there may be lots of other things you might find in textbooks under the general examination of cardiovascular, which I am not bothered. So any system examination, whether the child lies on the bed comfortably or not, better to start with the growth of the child, averagely built, thin built, or overweight. These are your impression, right? You can't say 100%. And lying comfortable on the bed or having respiratory distress is something important in CVS and RS examinations. And if the child is dysmorphic, you have to appreciate that usually we will give cases with Down syndrome. 99% of the it will be Down, but very rarely you might get other syndromes, but it's not your task to diagnose. So come to a conclusion of the syndromic diagnosis, what we mainly focus on the CVS examination. Cyanosis and clubbing, these are very basic things, right? So if you say clubbing, then we might ask, okay, which grade of clubbing? So it's handy for you all to have these kind of things in your mind. So how to grade clubbing, right? Cyanosis also, you might overdiagnose cyanosis, you might underdiagnose cyanosis also. That is also very common in the exam. Because mild tinge of purplish discoloration may be normal sometimes, but you have to take the case in overall, right? I'll tell you. Oral cavity, it's important, but don't try to examine oral cavity in a young child, right? And it's important to look for features of infective endocarditis, and especially even if you do not look at it, better to comment it in the at the time of your presentation, like no features of infective endocarditis. And it's important to comment on or look for features of heart failure. Features of heart failure, it's a general comment like you're not specifically looking for it. If there's tachypnea, if there's tachypnea, tachycardia, and in young infants, it may be sacral edema. But I have never seen an infant with sacral edema due to heart failure because in the exams, because most of them will be on diuretics at the time. Why not to look at oral cavity in a young child is child will start to cry and then you will lose rest of the physical signs. If it is possible, if the child can open his mouth, of course you can do it. But what I'm telling you is like don't try to put a spatula to examine the oral cavity in a case of cardiovascular system examination, right? Right. So peripheral cardiovascular system examination pulse is very important in children. So like in adults, rate, rhythm, character, volume, peripheral pulse, radio, radial and radiofemoral delays are very difficult to identify in children. So at your presentation, you look for it, but as a tip, I am telling you, you are not going to diagnose any condition based on radio, radial or radiofemoral delay in children. I am telling you practically. In theory, yes, because their heart rate is very high in children. It's a difference of a millisecond, which you will not be able to appreciate the delay. So you just demonstrate that you are going to do it, but at the time of presentation, just say radio rate. I'm telling you in pediatrics only, right? In adults, I don't know. I have never found a patient which I could appreciate radio rate, radio femoral delays. But look for it. Show the examiner you're looking. So there's another thing in pulse like collapsing pulse. I have forgotten to put it in probably around 14, 16 years of age. Sometimes children with rheumatic carditis can have mixed pathologies like aortic regurgitation and mitral regurgitation both. In that case, if there's AR, you can have this thing, collapsing pulse. But look for pulse. Please count pulse rate for at least 1 minute. So then can we comment on radiofemoral delay? Just say no radio, no radiofemoral delay. You can say no delay, but that maybe you would have not appreciated it. You can say, is that okay if we can't examine murmurs with changing position in young child like put the left at? Yes, I mean, it all depends on how old the child is, right? We don't usually, because putting the child on the left side, I have not come to auscultation yet, I'll discuss it. Otherwise, so I will not answer your chats then and there, because otherwise it will disturb the flow, right? So please have an idea about the normal pulse rate in children. Most of you will come and say pulse rate is 72. Most medical students pulse rate finding is 72. To be honest, you don't actively calculate this pulse rate at the exam. You just demonstrate us that okay, you are going to do, and even if you count it at the time of presentation, you can't remember it. That's a commonest thing. So because of that, have an idea about normal pulse rate in children. If you say a pulse rate less than 100 in a child whose age is less than 3 years, I know you have not counted it properly, right? So because of that, because in newborn pulse rate is up to 160. 1 year 130s, 40s. 2 years definitely above 100. 3 years definitely above 100. 4, 5 years maybe around 96 like that. only about 10, 12, 13 years, you get the adult heart rate about 72, right? Usually rhythm is normal in children. You don't get a child with atrial fibrillation, heart blocks and all in your cardiovascular system examination. If you have a child with very low heart rate like bradycardia, maybe heart rate around 40, 50, then it will be a very rare case of congenital heart block, but we don't usually give that kind of cases in, not that we are not giving it, we can't find these patients. So it's important to look for femorals, but you might not appreciate femorals in a bigger child because of the sometimes the fat mass and all. But if you can palpate dorsalis pedis and posterior tibial, that means femorals has to be there, whether you feel it or not. Even if you do not feel femorals, if you feel dorsalis pedis or posterior tibial, just say all the peripheral valves are present. Be careful on commenting because most of the medical students and even we tend to say, okay, all the peripheral pulses are present. But keep an eye, be careful if you are going to present whether pulse is there on the side of where the BT shunt was happening. So sometimes if you see a surgical scar on the back of the scapula, that means child would have undergone a BT shunt. That particular side, pulse may be weaker than the other side. Sometimes pulse may be absent, right? That is why we have to be careful about the age of, if you think that you can do it, just do it in the way you do it in adult. But I don't think you need to measure these things. But if it is obvious, like engorged uh, veins, you might feel it. It's better to ask, or it's a must for you to ask blood pressure before you turn to the examiner, because you majority of you will remember blood pressure at the time of presentation, because in your presentation you have an order in which blood pressure is there. So now when it comes to that level, okay, you will realize, okay, I did not ask about blood pressure, and then you are going to give a blanket statement, so I didn't do blood pressure, right? Because certain diagnosis can be made or can be assisted with blood pressure measurements. Like, so if you say, I want to do blood pressure, if it is a case of coarctation of aorta, we might say, okay, the blood pressure is 150 over 100. If it is wide pulse pressure, I mean, if it is AR or PDA, there may be very wide pulse pressure. In that case, we might tell you the figure, right? Some candidates, we ask you to check blood pressure as well, right? Yeah. So I'm going to look at your chats now. Check pulse rate for 30 seconds or 1 minute. Pulse rate 30 seconds enough. Respirate rate 1 minute, right? So if you are going to tell pulse rate, just give a even number. Don't say pulse rate is 95, right? Sir, in young child 4 to 5 years, do we need to check collapsing pulse? If you think you can do it without any hassle to the child, do it in all children and show the examiner that you are doing it. You can have certain diseases like PDA is a cause for collapsing pulse, right? Is it okay to remove the mask to look into the mouse? Yes, you remove the mask and put it back. Sometimes at the time you are trying to do that, examiners will ask you to not to do, right? You can ask examiner, is it all right for me to look for dental caries and oral hygiene of this child after removing the mask? Then we know, right? But at the time of presentation, no point. Can we say when presenting that I can't comment on JVP because child is not at a 45-degree angle position? Well, you can say, but I don't know in adults how because sometimes we might put children under 45-degree angle on the bed. So you wanted to have an excuse, but we might not give that excuse every time, right? I don't think pediatricians will penalize you. How could you comment on JVP if you have not put a child on a 45-degree angle? Because pediatricians are not that keen on this jugular venous pressure, but it for the sake of completeness, in a way you do it in adults. If you can do it in a child, so that means we can tick the box. Okay, this candidate has looked for it. This candidate has asked for blood pressure. Can we say that the JVP not elevated in this position? Yes, sometimes you can ask the child to, or you can put your hand underneath and just lift the head. So even if you forget this jugular venous pressure, you can still get a distinction mark, right? Don't go behind this jugular venous pressure. But I'm telling you, you might get a child of 16 years, 14, 15 years with some abnormal JVP, right? Very rare, very rare. But as a component, it should be there. That's what I said. Right. So then precordial examination. So precordial examination inspection, it's very important to tell about chest deformities, scars and visible pulsations. Whether you tell visible pulsations or not, it doesn't matter. But if you see visible pulsations on the left side, then you are pretty sure that you are not dealing with a case of dextrocardia. But very important to look for surgical scars, because surgical scars are hidden. We don't usually keep surgical scars for in public, right? So that's why surgeons put surgical scars under the scapula, under the axilla places. So you have to actively look for. And palpation, mainly 4 components. So apex speed is one. You have to look in both sides. So your CVS exam, I would say start with not missing femoral pulse. If you find a case of absent femoral pulse, then even without keeping the stethoscope, you know that's a case of coarctation of aorta. If you find apex beat on the right side, then without putting stethoscope, you know this is a case of dextrocardia, right? So usually thrills. For thrill palpation, you use this area of the hand. For heaves, you use this area, right? That's what standard textbooks say. But heaves can be examined like this even. You can put your fingers like this in intercostal spaces like this, right? So heart sounds, very rare to palpate heart sounds in children. Don't come and say, I felt I could palpate the second heart sound. I have never palpated, right? Thrills, of course, thrills are common in children, right? Parasternal heaves, yes, you can have parasternal heaves in tetralogy of Fallot conditions, but this is palpation. So auscultation. Now we have talked about general examination. We have talked about peripheral cardiovascular system examination. Now I am talking about precordial examination, in which I have talked inspection and palpation. Now I am going to discuss auscultation. So there has to be an order in auscultation. You can't just keep your stethoscope here and there. Start with apex, left lower sternal ledge, here, then pulmonary, then aortic area, right? That has to be the order. You have to concentrate mainly on where the murmur best hurt, nothing else. Heart sounds, of course, heart sounds will be there whether you like it or not, but you are trying to focus where the best heard murmur. Usually we will not give cases without a murmur, right? Usually we will not give cases without heart murmurs, right? Keep that in your mind before going to tell you did not hear a murmur. Think twice. If there's no murmur, that patient might not be eligible for the exam. Like that's the way we think. But with this corona thing, sometimes we don't know. If we can't find patients, we might give normal patients. But if you don't hear, just say you didn't hear, that's fine. But if you are going to tell that statement, please check 3 or 4 times. Am I going to hear a murmur or not? Sometimes the examination environment is noisy. Sometimes you might hear someone else is presenting something else, right? Where your ears are moving towards those kind of gossips, even at the exam. Sometimes you are more concentrating on what examiners are discussing, right? So you might lose the concentration. Please concentrate first, second heart sounds and where are the murmur best heard. That's the key in children. So heart sound, single second heart sound is there in top. So each heart sound has 2 components, but only second heart sound we have A2 and P2 classical differentiation. So in tetralogy of Fallot, you will hear only P2. This is a very difficult interpretation, right? But at the time of presentation, if you think that this is a case of TOF, present that second heart sound was single. That's it. That's how I do. I can't appreciate it. Sometimes whether this is second heart sound single or no. Splitting, fixed splitting is something which you all can appreciate. At your level, you should be able to appreciate fixed splitting, right? If you can't listen to split, you can just go through Google and listen to these different murmurs, right? Loud second heart sound is seen in pulmonary hypertension, okay? And gallop rhythm means the third heart sound. You can see it in any case of any heart failure condition. That's heart sound. Then come for murmur. So most important thing is best heard area. Even if you do not know how to differentiate diastolic from systolic murmurs, in children, just say you heard a systolic murmur. If you're going to tell you heard a diastolic murmur, that means you have to think so many times. I have never come across a child with congenital mitral stenosis, right? Even in rheumatic heart carditis in children, what is common is regurgitations than stenosis, because in pathology, stenosis takes time, but regurgitations are acute in rheumatic valvular disease, right? So it's important to know whether the murmur is radiating or not, right? Especially murmurs heard in apex and pulmonary area and aortic area. Whereas murmurs you heard in tricuspid or left lower sternal edge might not be radiating. These murmurs will be heard all over the precordium. But if you see a murmur, if you hear a murmur best heard on the apex and which is radiating to the axilla, that is MR. And if you hear a murmur best heard in the pulmonary area, which can be heard in the same intensity on the back, that is pulmonary stenosis. If you hear a murmur on the aortic area, which you can hear it on the carotid area also, that is aortic stenosis, right? And if you see a surgical scar, please auscultate on that surgical scar, because sometimes that surgical scar may be due to an underlying shunt, like BT shunt. So in that case, other than the murmur due to the heart lesion, you will hear a machinery murmur due to the blood flow through the shunt. If there's a thrill, murmur grading will be above 4, right? If there's no thrill, less than 4. So in your exam, most of the time, murmurs will be grade 3 if there's no thrill. If there's a thrill, most of the time it will be grade 4. Right? I'm telling you tips. Don't go and tell anywhere else that pediatricians told that in children, murmurs can be grade 3 and 4. I'm telling you to pass this exam, not to invent grade 1 murmurs, right? If there's a grade 1 murmur, we might not give it in the exam, right? Uh, right. So how to work out? Now you know large number of disease conditions, but when it comes to exam, it will be around 4 or 5 diagnoses. So you are correct. Even if you don't hear anything, there's a chance for you to give the correct answer about probably 25 to 30% of the time. If you find cyanosis, unless proven otherwise, your diagnosis is tetralogy of Fallot. Whether you like it or not, that's the case. So don't try to diagnose or give other conditions like transposition of great arteries, tricuspid atresia, double outlet right ventricle, truncus arterial. Lots of cyanotic heart diseases are there. But at your level, if you find a child with cyanosed child with a best heard murmur on the left upper sternal edge, then be smart and tell features compatible with tetralogy of Fallot. Try to score marks by looking at complications of TOF, like hemiplegia and brain abscesses. So those are distinction points, right? So in practice, I'm telling you, in exams, children with cyanosis highly likely to be tetralogy of Fallot, right? But child with cyanosis with a surgical scar in midline, and you can hear a murmur all over the place. Sometimes you can just say, okay, this is a case of complex cyanotic heart disease, but most of the time tetralogy of Fallot. So be conscious, try to figure out whether the child has got cyanosis or not. That's your first task. If you miss cyanosis in a child with cyanosis, you will fail. If you do the vice versa, you might not fail, but you might get a low score. Right? That means you're going to diagnose cyanosis in an acyanotic child. Right, so I'm just going through your questions. Sir, is it better to give a running commentary or last person? No running commentary. Running commentary, because you can't do running commentary in children, because sometimes you are doing it in a haphazard way in a child based on the age of the child. So always prepare to comment at the end. You just keep your back straight and give your findings. That's an art. Can we say JVP? I'm not going to talk about this JVP anymore. If you can forget about JVP, that's fine. So if we forget to examine some part of the, can we say yes, I forgot to examine this part, this component? You can say, right? Is it necessary to lift the child? Yes, you can do that if the child is big enough, right? Should we auscultate right chest also? Yes, it's very important. Sometimes you might feel apex beat on the left side, but you can hear more intensity on the right side. Should we perform the maneuvers like turn child to left side or make him seated to listen? Yeah. Yes. Now, if you see a child probably around 4, if you think that this is not a case of congenital heart disease, if it is rheumatic like in origin, if you, especially you will have to do this, I will come to that. If you hear a murmur on the apex, can you explain scar location and possible reasons? I have slides for you. Brain abscess, you are just going to look at the surgical scars on the head. So there may be burr hole incision surgical scars. Do we need to do maneuvers for AR? Yes, in certain age, certain cases, I will tell. No combined valve diseases in pediatrics. In adults, you can diagnose this, but pediatricians are poor. We can't diagnose combined valve lesions. If it is MR, yes, MR. AR may be there or not, right? If dextro, are we going to get murmurs with dextro? Yes, yes, yes. So, can we collapse in pies? I'm going to discuss only important questions, otherwise I don't have time. Right, so acyanotic, cyanotic. So if it is cyanotic, tough, that's why I have put not a mistake. If it is acyanotic, PST, PSP, PVD and ACE has to be there. AST also there. When I was a medical student, if I do not hear anything, the diagnosis I'm going to give the examiner was AST. That is something which you don't get lots of physical sounds. But PS, you will hear a very good murmur. So systolic and diastolic murmurs are extremely rare due to congenital heart disease. Keep that in your mind. Because diastolic murmurs are very difficult to hear in the presence of heart rate of 100. There's no diastolic time, so that's why you can't hear. So systolic murmurs are very common. Almost always try to differentiate whether this is ejection systolic, pan systolic or machinery murmur. That will be your task. If systolic, where the murmur best heard. So best heard murmur is the key in pediatrics. So I'm going to discuss this in detail. Don't try to diagnose or give incompatible things. Now, if you hear a murmur at the apex, okay. If you hear a murmur best heard at the apex in children, if it is not diastolic, it's very rare in children. This murmur, whether you like it or not, pansystolic. You can't have an ejection systolic murmur at the apex. Now don't look at PubMed and Google and say how many murmurs you can hear, how many ejection systolic murmurs you can hear at the apex. I am telling you to get through this exam, not to become a cardiologist, right? In your exam, If you hear a murmur best heard at the apex, that has to be a pansystolic murmur. That is, unless proven otherwise, mitral regurgitation. So this scenario will come to you in the presence of rheumatic valvular heart disease. So the child will be around 14, 15, 16 years. If you, because you start your auscultation with this, if you hear this, okay, then you have to look for aortic regurgitation murmur as well. But if now you know, you can justify why you are going to look. If you are that competent and a child is probably around 16, 17, you might hear early diastolic murmur of AR as well. But if you can say MR with axillary radiation and child has got heart failure or not, then you will get full marks. Okay, then you hear left lower sternal edge. In left lower sternal edge also, if the murmur is best heard in left lower sternal edge, whether you like it or not, that murmur is pansystolic. Whether you like it or not, it will be pansystolic. Now don't try to figure out, okay, I heard a murmur on the tricuspid area, but which is ejection systolic? Now what I am going to do? Don't try to invent diagnosis at that time. We don't mind whether it's pansystolic or ejection systolic. If you find a murmur with a trill or without trill, if you can say that, we are happy with that. But the thing is, for you to score marks, so tricuspid area, pansystolic murmur in a child, it's almost always VST. Right? Concentrate where the murmur best at. One problem is your stethoscope is larger than what we have. Now don't come and say we didn't have pediatric stethoscope, that's why I couldn't get through the exam, right? But even with that, you should be able to localize where the murmur best hurt. So sometimes in small children with your stethoscope, so the whole chest is can be occupied by your stethoscope. So in that case, sometimes it's difficult, but please concentrate where the murmur best hurt. That's the key. If you hear murmur best heard in the apex, then it has to be pansystolic. If it is tricuspid area, it's also pansystolic. This is the commonest case. So ejection systolic murmur at the pulmonary area. Now assume that you didn't hear anything, right? Okay, you can say the examiner, honestly, I didn't hear anything. Then we might ask, okay, do listen again. If you get that command, that means definitely there's a murmur which you have not heard, right? If you want to guess, you can jolly well say it all depends on the age of the child also. I heard a murmur because if it is a small child, VSTs will be usually closed or operated by about 3-4 years, unless it is a mid-muscular VST, right? But you can say if you hear a murmur best heard on the um, tricuspid area, then that definitely VST. If you hear a murmur on the pulmonary area, that will be an ejection systolic murmur most of the time, or machinery murmur, or very rarely you can hear pansystolic murmur towards the lower end of the pulmonary area. I'll tell you the differential diagnosis. So if you hear a machinery murmur, pulmonary region or the under the scapula in a small baby, so you are going to diagnose PDA in small babies like less than 1 year, right? Because most of the other patients would have had the treatment. So it will be PDA. In that case, your pulse will be high volume and the blood pressure will be high pulse pressure. And if you hear ejection systolic murmur in the pulmonary area, there will be two diagnoses specifically. That's pulmonary stenosis and AST. It's a matter of differentiating that too. I'll come into next. So pansystolic murmur in the pulmonary area means some VSTs can be high-lying, right? So high-lying VSTs, you might hear pansystolic murmur in the left upper sternal ridge. This is bit rare. If you hear best heard murmur in aortic area, it will be ejection systolic, and in that case, look for carotid radiation. So this is your syllabus. Now I have been collecting patients for this final MBBS exam since 2014, since I joined this university. Beyond these differential diagnoses, so beyond these differential diagnoses, I have never come across a child with any other heart conditions, right? There's an entity which I'm going to discuss in next slide. That means complex, you will not be able to give a diagnosis, but okay, you can say this child has got complex congenital cyanotic heart disease, but I can't give an exact name of the disease. That comes when there's a surgical scar, right? I'll discuss that in next slide. Now, if you hear a murmur best heard in the pulmonary area, so pulmonary stenosis murmurs are usually loud, right? If there's a thrill in the pulmonary area, that is PS. Because PS children are well grown, they don't compromise any pulmonary, they don't get any pulmonary edema. ASTs could be loud, but most of the time murmurs are soft. In PS, second heart sound is single, but in AST, splitting. PS murmur can be well heard over the back, but no such feature in AST murmur. You can have parasternal heave due to right ventricular hypertrophy in PS, but it is not the case in AST. And Noonan syndrome is a syndrome in which you get PS. AST is common in a syndrome called Holt forearm, in which forearm is deficient. Now, in some faculties, I have come across students are presenting, okay, this child has got a AST, but no evidence to suggest of Holt forearm syndrome. So that is full marks, right? Okay, now how you are going to present. Let's see, go through the chat. Could you please repeat pulmonary area again? So pulmonary area could be three possibilities. One is ejection systolic, one is pansystolic, one is machinery. If it is machinery with bounding peripheral pulse and the child is young, that's PD. If it is ejection systolic, could be two possibilities, PS or AST. I have given you how to differentiate that. To listen the radiation, you have to examine the back just below the scapula. If you hear murmur on that side also, that is PS, right? So scar, I'm going to discuss about scar. So how can we comment on aortic and pulmonary areas in dextrocardia? So that's why I said in dextrocardia you get murmurs, but you can't comment on whether this is pulmonary or this thing where everything is upside down. You can say, I think if you diagnose dextrocardia and murmur, that's more than enough. You will get even 100 out of 100. You can say, okay, I think this child has got a complex congenital a cyanotic or cyanotic heart disease with dextrocardia. And if you find dextrocardia, it's very important to comment on liver dullness and features of bronchiectasis to say, okay, though this child has got dextrocardia, child has not got any situs inversus, right? Here are my distinction marks. So how are you going to present? Now I thought to give you a template. We don't encourage you to do these, but when I was at your stage, I would have loved this kind of a thing. So how are you going to present? So keep your back straight, keep your arms behind or wherever in a comfortable way. Don't move here and there, right? Take a deep breath and organize your thoughts and start. So I examine the 6-month-old baby girl's cardiovascular system. Use short sentences with pauses because we are not good at making long sentences under stress, right? So she is lying comfortably on her mother's lap. She seems to be adequately grown for her age. I have missed her, but I would like to measure her weight and length. So it's important to say length rather than height. Less than 2 years, we measure length and plot it in CHD. She has no cyanosis or dysmorphic features. There are no peripheral stigmata of infective endocarditis. So you would have missed certain things here like oral cavity missed, but not a problem. In 6 months, you might not see even tooth in this age, right? It's silly to look for dental caries in a 6-month-old child where you don't have even teeth. So her pulse rate is 130 beats per minute, which is regular in rhythm and normal in character. I could feel all peripheral. So use different sentences, types. So her pulse rate, then I could feel like that, like this. I could feel all the peripheral pulses and there was no radial or radiofemoral delay. You could not appreciate. It may be there, but you could not appreciate that's possible with this much of high heart rate. There were no surgical scars in the precordium. Her peak speed is at the 5th intercostal space, left mid-clavicular line, which it's very important to say left side or not, which is normal in character. You can't diagnose thrusting, heaving, that kind of effects in children. In adults, yes. There was a thrill at the left sternal edge. There was no parasternal hip. There was a thrill at the left lower. I just did all these things in a rush. Both heart sounds were heard in normal intensity and character. There's a grade 4 pansystolic murmur, best heard in the left lower sternal edge. I looked for any evidence of heart failure, but there was no tender hepatomegaly or bibasal crepitations. I looked for. These are the sentences which you can use. My conclusion is that this child is having ventricular septal defect without any evidence of heart failure, pulmonary hypertension, or infective endocarditis. That's your conclusion. You can jolly well get full marks, and then discussion we might ask, okay, what are you going to do? How are you going to know whether the child has got heart failure or not? What are the heart failure signs, symptoms, management? These are theory. Now, this will be a common kind of case for you all because nowadays children get early heart surgery compared to probably 20-30 years ago. So this is how I look at a child with surgical scar in chest. So if you see a surgical scar in the chest in your cardiovascular system examination, It may be related to heart, maybe not related to heart. So if it is a cardiac related one, that surgical scar could be a palliative procedure or a curative procedure. If it is non-cardiac, because lateral thoracotomy scar could be due to tracheoesophageal fistula as well. මොනවද මේ මෙච්චර chat දාන්නේ? Yes. Fifth intercostal space is a possible place to feel the apex beat. So when precordial examination finish, is it needed to is it needed to offer to do extended examination? No, you don't need to offer. You have to do it. You have to look for. You have to look for the tender hepatomegaly and bibasal repetitions. In dextrocardia, going to comment on bronchiectasis? Yes, you can say. Like you might hear post crepitations when you look for because heart failure you will hear fine crepitations. If it is bronchiectasis, you will hear post crepitations. Right? If we get a child with bronchiectasis, we will put it under respiratory system, not under cardiovascular most of the time. Right? So probably I will not be able to answer your chats. We are running out of the time. I have to finish this in half an hour. So cardiac lesions could be palliative surgeries or curative. So how to approach to a child with surgical scar in the chest? So have an idea about common surgeries that these children undergo. So there will be three possibilities, I would say. Midline sternotomy, lateral thoracotomy, subscapular scar, right? Left lateral or right lateral. Now, if it is due to a shunt procedure, like in tetralogy of Fallot, if you see a scar on the back of the scapula, that is unless proven otherwise, BD shunt scar, right? So different murmur over the scar means there's a shunt. And you can hear only one murmur, but there's a surgical scar. So it could be due to two reasons. Highly likely a residual child would have undergone a curative procedure, but there's residual VSD or some residual cardiac lesion is left. Right? So the other possibility is child would have undergone a palliative surgery like pulmonary artery banding in VSD. Or in certain cyanotic heart diseases, stage-wise surgeries could happen. Like there are conditions called procedures of Fontan, Glenn procedure, like us differently, you don't need to know, but that. So if you get a child with acyanotic child, surgical scar is there, and you could hear one murmur, okay, that is probably a residual heart defect or a palliative. If you see a child with cyanosis and surgical scar, it could be, if it is an anterior surgical scar, that could well be a stage-wise surgery. First stage would have happened. But if that scar is on the back of the scapula, on left or right side, that will be due to B tissue, right? So these are the scars, right? Here you have to look, right? This is a scar. This is anterior scar. So see how we are going to. So I examine this 4-year-old boy who is lying comfortably well on the bed. He seems to be adequately grown for his age, but I would like to measure his weight, height, and protein CHDR. He has I think he has got He has got central cyanosis and grade 3 finger clubbing. Right? He doesn't have any dysmorphic features. There are no peripheral stigmata of infective endocarditis. His pulse rate is 100, which is regular in rhythm, normal in character. I could feel all peripheral pulse. Here you can mention, especially on the left side radial pulse as well, because the next sentence is this child has got a left subscapular region surgical scar. So there's a surgical scar in the left subscapular region. Now in your exam, I have frequently encountered medical students are telling CVS proper. Right? So you talk about general examination, CVS proper. There's nothing called CVS proper. Pulse rate and everything is CVS proper. Right? You can say, if you want, okay, precordial examination reveals that this child has got a left side subscapular region surgical scar. Stop it, that point. Then that's inspection. So apex plate is at the 5th intercostal mid-clavicular line, normal character. There was a thrill at the left upper sternal edge and right side parasternal. Both hearts also heard, and there are single second heart sound. There's a grade 4 ejection systolic murmur best heard in the left upper sternal edge. The 3 don't come and present like grade 3 murmur. That's incompatible. If there's a thrill, then murmur has to be grade 4. Which is radiating to the back means exactly the same place on the back of the chest. And there's a machinery murmur over the surgical scar. So my conclusion is that this child is having phallus tetralogy, or you can say congenital cyanotic heart disease, highly likely tetralogy of phallus, with a functioning Ballock's perfusion without any evidence of heart failure, pulmonary hypertension, or infective endocarditis. I could not find any evidence of brain abscess or hemiplegia-like complications in this type. Right? Okay, that's cardiovascular system. So take home message is, try now in pediatrics. We are dealing with congenital heart diseases. So most of the time we are going to give you VST, AST, TS, these three. Rarely you will encounter aortic stenosis and coarctation of aorta as congenital. If it is an older child, probably around 13, 14, 15 years old, it could be acquired heart lesion unless proven otherwise mitral regurgitation. Look for aortic regurgitation. That is my key message. If you are confident that this is a congenital lesion, no point looking for early diastolic murmurs. Right, let's go to respiratory system. That has, oh, I have forgotten one. Percussion, right? So general inspection, palpation, percussion, auscultation. So growth, lying comfortably well on the bed, respiratory distress or not. Cervical lymphadenopathy is important in RS, but not in CVS. Throat examination, you can get the permission because ENT examination comes under respiratory system. Cyanosis and clubbing in respiratory conditions are very rare in children. BCG scar needs to be presented, but MAN2, if it is there, comment, but don't say MAN2 is not there. That means you expect all patients to have MAN2 marks. Right? Don't be silly in that kind of statements. If PG scars, BCG scar is there, that's important. But if MAN2 mark is there, you can say. If it is not there, you don't need to say that. And so this is a likely case. So dengue recovery rash can be there and PCV marks over fingerprints. The pleural effusions in children are most likely due to dengue fever. Pleural effusions in children are highly likely to be on right side as well because of that reason. So very few cases. So lobe pneumonia, pleural effusions. Out of that, I would say pleural effusion is the commonest. Asthma exacerbations, bilateral lung signs. Bronchiolitis, bilateral lung signs, but child has to be less than 1 year. You can get these children as well congenital laryngeal stridor. In that case, you will hear it. Then bronchiectasis. So inspection, you can just flash a light into the nose because sometimes nasal polyps, chest deformities, chest movements. Go to the foot end of the child and kneel down and keep your eyes at the level of chest movements and just see whether movements are there or not, right? You have to count respiratory rate for 1 minute. So keep your hand on the abdomen, look at your watch and count for 1 minute. But that 1 minute, other than counting it, just have a look at other places as well, like fever chart, cannula, um, likewise maybe respiratory distress, breathing pattern. Likewise, you don't waste that 1 minute only to count respiratory rate. You can gather lots of other things, right? Keep and be aware about normal respiratory rates in children. So you are highly likely to tell adult respiratory rate values when you come to pediatric cases also. So these breathing patterns, abnormal breathing patterns, will not come into an exam, right? But better to know. So these are the chest deformities. This is pectus carinatum. This is pectus excavatum. This is Harrison sulcus with pectus carinatum. So these lateral things are, so these are the chest deformities. Tracheal positioning is, it's very difficult to comment in children, but try to do it in an older child, but don't try to do it in a probably in infants. Your finger may be larger than the suprasternal notch, and especially don't try to do this in a child with congenital laryngeal stridor. Chest expansion, you have to keep your hands like this and see whether it's expanding. So vocal fremitus, if you are going to do with your stethoscope, you don't need to do it through your hand. So this first place is the best position. You ask the child to keep hands like this, and your scapulas will be move apart. But in this age, little young age, you will not be able to ask children to do that. You will have to do with probably the most comfortable way to the child. So auscultation, go in this order, zigzag, right? Zigzag order. Go top to bottom laterally. It's like Christmas tree pattern, right? Likewise. And auscultation, now in your respiratory system examination, tip is, first thing, try to see whether this is a localized lung sign or generalized lung sign. Narrow down that first. Okay, that's how I do. If it is bilateral, so then it will be bronchopneumonia, aspiration pneumonia, viral pneumonia, bronchiolitis, or even bronchiectasis. If it is unilateral, okay, effusions of lobe pneumonia. So vesicular breathing and bronchial breathing. So most of the time in children, bronchial breathing is not heard. So In vesicular breathing, expiration is shorter than the inspiration. There's no gap in between, but in bronchial breathing, expiration is longer or equal compared to the inspiration, and there's a gap. One of the difference in children is in adults, you might hear bronchial breathing due to lobar pneumonia. But in children, you will hear reduce air entry rather than acute. Bronchial breathing, you will hear reduce air entry, because reduce air entry in a child on one particular side could be due to two reasons. One is effusion, one is lobar pneumonia. To differentiate that, percussion is important, right? How to narrow differential diagnosis. So this is how I do. First, see lung size on both sides or one side. Now, when you put your stethoscope, concentrate what I am going to do. Concentrate whether you are going to see any difference in either side. Doesn't matter what the difference is, right? If both sides, think about asthma, bronchiolitis, bronchopneumonia, aspiration pneumonia, bronchiectasis. If focal, lobar pneumonia, and pleural. If you are not sure whether there's a difference in one particular, go and re-examine, right? Then try to work out on air entry, reduce air entry. Now, if it is focal means you will know it's focal because it should not be then. It should come to here, right? Yeah. If focal, try to work out on air entry. If reduce air entry, effusion, pneumonia. Think about lobar pneumonia and pleural effusion if there's only one side. So this is how you can present. So I examine the respiratory system of this 10-year-old, maybe you can say young boy, happy child, or young lad නම් කියන්න එපා අපේ උන්ට. So you can mention about some adjectives, right? He seems to be overweight for the age. However, I would like to measure his anthropometric measurements and plot it in the chart. He has no cyanosis of finger clubbing. His BCG scar is present. There is no cervical lymphadenopathy or nasal polyps. He has a macular rash over lower lips. His respiratory rate maker. There are no chest deformity. Chest expansion is equal on both sides. I found positive physical signs. This is how I present. I found positive physical signs mainly on the right side lower zone, in which the percussion note was stony dull and there was reduced air entry. There were no creps or wheeze over the area. And vocal resonance was reduced. He had normal percussion note, vesicular breathing, and normal vocal resonance in rest of the all other lung fields. In conclusion, I think this child has got a right side pleural effusion, probably secondary to dengue hemorrhagic fever, because he has got a convulsant rash and few finger pricks marks for suggestive of PCVs, right? Okay, so I will not go with this abdominal thing now. So I will do another session on abdominal examination, CNS and developmental assessment, right? So your cases will be starting on 8th of February, right? Probably I will not be able to do it in this week. I have lots of lectures to be done on 29th. So I have 2 lectures to prepare. So the week after that, that means the week starting with probably the 1st of February. In between that week, I will do one. So please, can you repeat the DDs for cyanosis with scar? So cyanosis with scar, if that scar is on the subscapular region, that scar is due to BT shunt on a tetralogy of Fallot, right? But the scar is in the midline and child has got cyanosis still, you can say this is a complex congenital cyanotic heart disease, would have undergone palliative surgery. That's why the surgical scar. How to examine vocal fremitus? The same way as you do it in adults. Sir, could we please get the slides? I knew you would ask for this. I will do it. There's nothing to hide. So if we ask to examine a joint, do we need to join? I don't think. We don't want you all to do P-gals and hip joint. That's a postgraduate thing. If you know P-gals, I'm happy. That's more than enough. Right. Okay. The other thing is we need your feedback because we have to provide some documentary evidence, right? So it's very difficult to get feedbacks from you. I don't know what's the reason, because now if I do this kind of an extra lecture, we have to provide the university your feedbacks and your request on doing these things. I don't know. Probably I will send a Google form next time to the batch rep, and then you can, because we have, my point is, if we can do these kind of lectures under routine lectures, where no one is going to teach these kind of things. But one problem is you all are not receptive to listen this kind of a thing only you come to this final stage. Now you all are receptive. You have to face this. But if I do this for 38 batch, participation will not be like this. Right. Okay. I'm going to stop this now. And I'll send another link probably next week, right? To do. Especially I will be targeting on developmental assessment rather than CNS, right? And the abdomen. Okay, I'll share the this presentation. I will take the abdominal component out and then rest of the thing in the ELMS, right? Okay. All right. Thank you very much.